This episode of Transmission Interrupted was recorded October 17th, 2024.
This is Transmission Interrupted, the podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Welcome to Transmission Interrupted from NETEC.
Hello and welcome to Transmission Interrupted. My name is Jill Morgan. I'm from Emory University Hospital here in Atlanta, Georgia. For those of you not yet familiar with NETEC, our mission is to set the gold standard for special pathogen preparedness and response across health systems in the U.S., with the goals of driving best practices and closing knowledge gaps and developing innovative resources. NETEC works alongside and in cooperation with the CDC and is funded by ASPR, the Administration for Strategic Preparedness and Response. Today, we are here to talk about Marburg, as in Marburg virus disease, or MVD. Right now, there is an outbreak happening in Rwanda, 62 cases with 15 deaths. And unfortunately, many of those deaths have been among healthcare workers. So for those of us who are geographically limited, Rwanda is in East Africa in what's known as the Great Rift Valley, just south of the equator. Beautiful agricultural, mountainous area. And it's not only agricultural, but it's a tourist destination these days. And so I think that always increases our concern that some of those things that perhaps are brewing in one part of the world can end up anywhere. So we're going to talk about Marburg virus disease today, and I'm just thrilled to have with me today a dear friend, Dr. Bhadelia, and we could not ask for better credentials. Dr. Bhadelia is the founding director of the Boston University Center on Emerging Infectious Diseases. She's a board-certified infectious disease physician and associate professor at the BU School of Medicine. She also serves as the senior policy advisor for global COVID-19 response for the White House, their COVID response team in 2022 and 2023, and the interim testing coordinator for the White House MPOX response team. She also is the founding director of CEID. She's just been involved in special pathogen care, either on the continent of Africa or in the United States for many years now. And we're just thrilled to have her join us. So, Nahid, welcome.
Thanks so much for having me, Jill. You forgot the way that we are both connected, which is we're both part of the Ebola response and during the West African Ebola virus disease epidemic in 2014, 2015. And we've known each other ever since.
That's right. So yes, I was here at Emory when we had our patients, so have a little bit of experience with Ebola here in the United States, and Nahid has a lot of experience with Ebola in other parts of the world. So perfect setting for this conversation today. Let's launch into this. I know only a little bit about Marburg. I know a little bit more about Ebola, and I know they're part of the same viral family, but we hear a lot more about Ebola over the years, at least, than we have Marburg. So can you give us a little primer on the background of Marburg and why that might be?
Marburg virus disease and Ebola virus disease are part of the same family of filoviruses, and they're negative sense, single-stranded RNA viruses. And what's special about these viruses, or terrible about them, is that they are much more likely to evolve. They have a huge range of animal reservoirs. Although for Ebola, it remains uncertain. For Marburg, it's a lot more clear story that where the virus lives when it's not in humans or in non-human primates is probably the fruit bat. That seems to be its natural reservoir. And Marburg traditionally has had much smaller outbreaks. I think if you were going to look at Ebola virus disease's trajectory before the West African Ebola epidemic, it kind of appears similar. You had smaller outbreaks in the 200s, 300s. The biggest one, I think, was in Uganda in 2001 for Ebola before the West African Ebola epidemic. Marburg has traditionally had smaller outbreaks, but you have seen larger clusters in Angola and South Africa where you had about 200 to 300 cases. So we hear less about it because until recently, the outbreaks have been a bit more sporadic and they've been smaller. And so there's been less scientific evidence that can be collected at any one time because they tend to fizzle out, thankfully, much faster.
Yeah. Does Marburg spread as easily person to person as we know Ebola does? I mean, I know that it takes contact with contaminated blood or body fluids, But it seems like, at least with Ebola, we saw it wiping out families and things like that. And I just, from a risk standpoint, both to healthcare workers, but also to the families and loved ones of and neighborhoods and communities, is there a difference between the two, or we just gotten lucky with one and unlucky with the other?
Yeah, I don't know that we have definitive studies to show that. Traditionally, Marburg has been sort of touted as potentially having lower mortality, because the first cases of Marburg actually were discovered in Marburg, Germany. It was an imported non-human primate species that was brought into laboratories in Spain, and Marburg led to 2 Marburg cases in laboratory workers with early mortality rate in some of these cases at 24%. But traditionally, you've seen other scenarios where the mortality has been as high as 80, 88%. So everybody says Marburg virus disease may have a lower mortality, but I actually think it's just the difference of where the disease presents, the health systems, how quickly patient came to care. I don't think that we have definitive question on the mortality issue, and I certainly would not assume that Marburg, for some reason, is also less transmissible. I would assume it's the same bloodborne pathogen. We know, just like Ebola, it tends to carry a lot more Ebola virus disease. Patients who have Marburg virus disease are much more likely to have higher amounts of virus towards the latter half of their illness when they are sicker, which means this is what places healthcare workers, as you mentioned, at higher risk as well. And again, same with families. One of the reasons that I think maybe the transmission was so driven within households during some of the other Ebola outbreaks might also be that patients were being cared for within the house while they were sicker, and that kind of increased the chances of transmission as well.
Yeah, absolutely. And I know a subject near and dear to your heart. Certainly, we know that within families of other pathogens, even just things like COVID, where people perhaps don't have access to healthcare, they're more likely to sort of suffer in silence, not have places that they can go to seek care that's affordable to them, and therefore they're being cared for at home. They may still be going to work and things like that. And so we know that that contributes to spread overall. And I want to get back to a point in just a minute about this outbreak being a little different and being in a higher resourced area. But let's go back to, what does this look like in a human? What do people need to be looking for if they want to add Marburg to their differential list on a traveler who might be returned to the United States or was over in Rwanda or the surrounding countries and might be concerned? So case presentation, what are people looking for?
Yeah, I think that the early presentation of both Ebola virus disease and Marburg virus disease is very nonspecific. I cannot stress this enough, right? So I must have taken care of, I think, like 500 Ebola patients during West African Ebola epidemic, and the range of presentation is so large. I had cases where there was a young gentleman who came in who could have had 2 days of flu and then no other symptoms, and that was his Ebola virus disease presentation, right?
Wow.
So the range of the presentations can be very, very large. The thing that I would caution is that if you see someone with a febrile illness, someone who has a malaria-like illness, right, and it's coming from this geography where the current outbreak is currently in Eastern Africa, in Rwanda, your suspicion should go up. And because early on, it presents as potentially just malaise, high fever, may progress to headaches, sore throat, I think was reported in the Equatorial Guinea Marburg outbreak, epigastric pain. The hemorrhagic features, both in Ebola virus disease as well as in Marburg, aren't really that manifested that overtly until much, much later, right? And I'm guessing probably very similarly, which is that you could have blood in emesis or blood in diarrhea if you have GI symptoms, or bleeding at the site of IVs. That the more horrific symptoms that I feel get Hollywood treatment don't really manifest in many of these cases with patients with viral hemorrhagic fevers.
Yeah, I agree. It's so funny when people ask me about the Ebola experience, and I tell them, for being named a viral hemorrhagic fever, I expected a lot more blood. Yeah. And I'm grateful that there wasn't. But yes, I do think it's sort of a misnomer. And I was laughing when you mentioned Marburg, Germany, because, of course, this is a perfect example of why we don't like to name pathogens after these places where they're discovered anymore, because they tell you nothing, right? It tells us nothing about the virus to say it came from Marburg, Germany. Anyway, I know people really thought that we should name COVID something different, but a coronavirus tells us more in the science side of things than calling it wherever it came from. So it sounds like the clinical presentation can be difficult to sort of ferret out, right? Especially as we head into maybe flu season. But over the course, say, for instance, these people in Rwanda right now, the clinical course, we're still talking about like supportive care, right? We don't have any countermeasures right now specific to Marburg, right?
Yeah. So why don't we talk about the treatment part of it first, which is exactly right, which is that there was more animal studies that were done after the Equatorial Guinea outbreak a couple of years ago that maybe moved the science forward a little bit, but we do not have any approved treatments for Marburg virus disease. The ones that showed potential promise were some antivirals as well as monoclonal antibody from MapBio that's targeted against Marburg virus disease in particular. And animal studies say that potentially the greatest benefit is if you can combine an antiviral like remdesivir with a monoclonal antibody. But all of these are experimental treatments. We don't have evidence of effectiveness in humans. Remdesivir, which is one of the antivirals that we use also in COVID-19, is on the WHO list for treatment for COVID-19, was actually available to a certain point in Rwanda. And that's not probably in the amount that was needed for this outbreak. So recently, what I'm hearing in the news is that remdesivir is going to be deployed as a potential treatment option as part of a trial for patients who might be sick with Marburg virus disease. So no evidence on treatment. Potentially antivirals. The trouble with antivirals, like remdesivir, similar to what we saw with COVID-19, is that you need to come to care very early. Antivirals work by blocking the replication of the virus when somebody's infected. Now, if you've been infected for a while, your body's already replicated, they don't tend to be as effective. And so the importance of finding people early probably plays a role in our understanding of how effective these treatments are as well.
Yeah, thanks. It's so key to make sure that we're getting people early and treating them early. And speaking of treating, so I think the treatment we gave to our Ebola patients, in contrast to the patients I give, the care I give to most of our septic patients in like a medical ICU, which is my background. And really, they don't seem that dissimilar, right? I mean, it's supportive care. And that doesn't mean, as my mother thought, I'm sitting next to them and patting their hand. It means I'm supporting their vital functions, right? So replacing IV fluids and things like that. What would be your key? Okay, I think this could be malaria. This could be Marburg. What should my initial treatment of these patients be if I were to encounter one?
Yeah, I think the biggest thing is first, of course, timely isolation, supportive care, as you mentioned. Depends on their symptoms. But I want to underscore what you just said. I think people hear supportive care and they think, oh, we just let nature take its course. And when we talk about the difference in mortality, right, when you hear numbers anywhere from 24% to 88% for Marburg, a big part of what's made a difference in the past is supportive care. How much care each of these patients got that was targeted to improving their organ support, right? Majority of what leads to mortality is a multi-organ dysfunction and sepsis-like picture that you define in this patient. Fluid replacement, so watching the blood pressure, ensuring that they maintain enough arterial fluid to make sure they don't drop organ dysfunction. Some of these patients may manifest co-infections, right? Malaria is still a possibility. So the interesting thing about malaria is that, particularly in pediatric cases, you can have hemorrhagic features of malaria. And it's very confusing in an endemic area, right? When you have a presentation, whether it's actually malaria or viral hemorrhagic fever. I had a patient in Uganda a while ago, a pediatric patient who was suspected to have CCHF, and actually was hemorrhagic malaria. And it's very similar presentations. So I think in treating co-infections, ensuring blood pressure, fluid replacement, electrolyte replacement, and monitoring for any changes in mental status in Ebola patients, but actually also in Marburg patients, it's been noted that you might have encephalopathy, mental status changes. I'm guessing, and there hasn't been evidence that I've seen, but at least there was evidence in Ebola virus disease that the virus can cross the blood-brain barriers. If that's the case, you may see something similar in Marburg as well. And Jill, you called me a font of knowledge, but I feel like you are the font of knowledge in that you've done an incredible amount of supportive care work. That unfortunately, the supportive care that I would have been able to provide or was able to provide to most patients in West Africa was quite minimal. So I'd love to hear your thoughts on that too.
Yeah, I think that we had patients, of course, I was seeing people who were repatriated, right? So these are healthcare workers brought back to the United States with Ebola. And I think what really struck me was when one of our patients, who of course we were letting them look at their own laboratory results, and, they felt like what they were seeing in their own laboratory results, because we were able to do these things like recheck electrolytes every 4 hours. They said, oh, this is probably why I saw some of the deaths I saw. It's not what you would see on TV. Like you said, the Hollywood treatment of hemorrhagic fever. These are people who maybe they're even recovering, or maybe they're even taking in some fluids, but we can't get enough in them. And these people would sort of sit up on their cot and basically just fall over dead. And that's electrolyte imbalances, right? So when we think about, if I could impress upon every healthcare system in the United States to do one thing, it would be, can you at least check electrolytes on a patient who might be septic? Whether they're septic with this or something completely different, that early intervention is so key to keeping things working correctly in their body, and including, of course, their heart muscle, right? Because all those electrolytes are making such a difference in those kinds of fundamental preservation of health.
And that's both the loss of the fluids, I think, from the gastrointestinal or emesis, right? I also think that it's partly because of their unlimited nutrition. Nutrition was a big part of WHO's recommendation, particularly patients who are in a population where malnutrition may be at baseline an issue as well. The other things that I'm going backwards, Jill, but I feel like this is an important point to make, and you'll agree with me. In terms of transmission, and I kind of want to make clear that Marburg virus disease and Ebola virus disease are not the same as COVID-19, right? They're not airborne. You can't transmit them. We know the way that they transmit is close contact bodily fluid. Certainly, I think somebody got emesis and there was aerosolization of the emesis, you'd be concerned, but that's why we put on the advanced personal protective equipment. But I see that because I think that it's important, even as we talk about this disease with high mortality, to say that, we can treat these patients pretty comfortably without risk to ourselves, as long as we put on the right personal protective equipment, right donning and doffing, and that includes the trajectory care, early access to care, hands-on care. So just to breed confidence in our fellow healthcare workers to say that this is something that can be done with the right PPE. To give you a sense, I'm not saying I'm encouraging anyone to do this, but when I was in West Africa, in one of the ETs that I worked with, I would stand without PPE 10 feet away across the barrier that separated the ETU to talk to an Ebola patient who was on the other side, because it was a lot clearer and better to understand, because, I didn't have this mask and lots of stuff. So I felt comfortable standing 10 feet away from them with a barrier in the middle on the other side of the hot zone to have that conversation. So there's nothing magical. It's just transmission-based, personal precautions that help us become confident as well.
Yeah, I agree completely. And I tell people, unlike some of the other hazards that some of our healthcare providers encounter, right? So thinking about some of the chemical things that can eat through your skin, and, there's all sorts of hazmat stuff that's super dangerous, even with some kinds of PPE on. We really are well protected. And I think just as rolling that into sort of this new mandate from Joint Commission, that every healthcare system, if you're Joint Commission certified, credentialed, you need to have a plan for special pathogens patients. And of course, they leave special pathogens as sort of largely undefined, but we're still talking about things that have a high risk of mortality, some transmissibility, and that you just need to prepare for in those ways of having PPE and people trained in PPE, people understanding infection prevention fundamentals and being able to follow them. And I think that that's absolutely right. I don't want people to think that we have identify, isolate, inform. The fourth I is not ignore. I can't put somebody in a room and just hope for the best while I call public health. That's not going to cut it.
Yeah, that's not supportive.
Right.
But so just, sorry to go back to transmission, because I feel like this is so to the point of treatment, right? Because treatment and supportive care is all about early intervention in these patients. And I feel like ensuring that our healthcare workers are prepared and are comfortable taking care of these patients is part of what we should talk about. So going back to the treatment thing, so oral antivirals, favipiravir, remdesivir, and then there is a oral version of remdesivir The company had looked at which is obeldesivir, which is looked at COVID. And my understanding is they were starting to do non-human primate studies for viral hemorrhagic fevers in animals. So there might be those options, compassionate use, expanded access protocol, if we were to get a patient here. But what Rwanda is doing is currently already actually, not moving from treatment for second-dose vaccines, they're actually already deploying experimental vaccine. So that's the Sabin SAD3 adenovirus vaccine which was actually in phase 2 studies in Uganda and Kenya, including with Mikere University, one of the partners that I worked with for a long period of time when on doing medic in corporal Uganda. So the advantage of having these trials in the region, I think one of the ways that Rwanda was quickly able to get the Sabin Institute vaccine, or the Sabin vaccine into the response, they've made the decision to not deploy it in a randomized controlled trial, but rather they're deploying it as a compassionate use of the public health emergency to every healthcare. I mean, the disadvantage of this is, of course, now we don't have advanced studies. We have phase 2 that have potentially might have shown some advantages, but we don't have a phase 3 efficacy study on it. So we missed the opportunity to do a study on it. But it's kind of a heart-wrenching decision to make on the part of the government. You tell some healthcare workers if you get a placebo and others that you're going to get a potential experimental vaccine that could show benefit. So they've deployed it, and I believe like almost 900 doses are already out. Is that right?
I think close to that. That's I think a fantastic thing that we can do that, and also a great example of why we want to be able to continue research and work on these things, even when they're not flaring up. You know, it feels so important that we'd be able to mobilize resources when these outbreaks occur. And it's so difficult when an outbreak might occur in a very difficult to access area, or it flares up and then dies down. There just isn't the opportunity to get there and do lab work and check things and do the kind of study that we would like to do to understand these things better. And I'm curious with this outbreak in Rwanda right now. First of all, Rwanda has a more robust healthcare system than I think we've seen this kind of outbreak in before. I wonder what your thoughts are on being able to do, as you said, sort of give these medications, even though we don't have complete studies that we would like to have. And we have these patients being treated in an area that has the ability to do things like check vital signs and check electrolytes and fluid replace. Does this hopefully mean better information coming out of this outbreak than we've had in the past?
Yeah, that's my hope. Certainly for natural history settings, I don't know how much the Ministry of Health is able to do in terms of capturing just data around patients, right, that they're going through this illness. I would imagine their capacity is a lot better for the reasons we talked about. Rwanda has been an exemplar when it comes to tackling other disease threats, partly because they have a strong public health system. They invested in that over the years. I think what's also helping is that after the West African Ebola epidemic, there has been a move to recognize that you can't tackle emerging infectious diseases in general and viral hemorrhagic fevers in particular without putting an element of research response into your clinical response. And I think this has been true here. If we see a patient here, I think it's similarly important that we have that. And the reason why is because the knowledge from the first 100, 200 cases of any new pathogen help us improve the care for the next 100 or 200 cases. And we've missed that opportunity in the past, but that infrastructure gets built beforehand. And since Rwanda has it, right, I think that we're going to be a little bit farther ahead of it. The good news is that it looks like their cases they're reducing. There's no new cases for a couple of days. And what I haven't seen, early on I saw that there were potentially a couple of unconnected contacts, right? My concern is that we haven't seen enough phylogenetic analysis or the ability to see how the cases connect to each other, how they transmit it. So are we missing pockets of disease? So my big concern would be, in terms of learning more about this disease, I hope there's strong phylogenetic analysis studies ongoing that are giving us a sense of how all these contacts are connected, but also if there have been contacts that have potentially traveled into DRC or Uganda on the more rural areas across the borders, and there'd be a concern about potentially tracking cases there as well.
Yeah. Yeah. We can never really completely let our guard down for any of these things. And being able to mobilize things quickly, being able to be prepared. And as you said, it's not magic. This is not something that people have to be immediately frightened of. They need to be reasonable about their precautions and think about, have it in their mind that this could be a special pathogen when somebody comes in febrile with travel history or a new exposure to anything. And I don't really care whether you've been to Uganda or Democratic Republic of the Congo or Sierra Leone. I also want to know if you're febrile and just got off a cruise ship. I want to know that, right? Because I want to be protected from any of the contagious things you might have, including norovirus.
Yeah.
So thinking about how we can anticipate those exposures, protect ourselves from blood and body fluids, and that means using PPE reasonably and consistently and correctly, I think is so key. If you could just wave your magic wand, and what would be on your list of ways we could do a better job in preparing here in the United States?
Yeah, I think that the infrastructure that NETEC has created is incredible, right? I mean, 10 years ago, this wasn't, or a little bit more than 10 years ago, this was not there. The resources that NETEC provides are incredible in terms of clinician education, capacity to potentially get engaged in research, capacity strengthening. I think that we need to recognize that we live in an age of epidemics, and that we need to ensure, and just as you said, John Commission is looking into that, there are hospitals that are prepared to do that. And, we just talked about how healthcare workers have to be confident, be able to put the PPE on. Well, they need to have access to PPE, and they need to be trained on PPE. And they need to potentially get the same kind of education over time about these diseases they don't see enough. That investment is never wasted. It's never wasted. And I think that's one way we prepare. The second is we ensure our research infrastructure is ready to go. That includes potentially deploying vaccine or natural history studies, or potentially a smaller, over multiple outbreaks, as we've done with Ebola virus disease, treatment, randomized control trials as well.
Yeah. I think I love the phrase, and yet it's a really scary phrase. We're living in the age of epidemics. I think you're absolutely right. When somebody mentioned, hopefully it'll be another 10 years before we see something like COVID, I was like, I'm not thinking we got that much time. And part of that is because we all like to go places. We travel, we interact, we're crowded together, and then we go places and have new experiences and get in contact with things, and then we bring them back together. But part of it is also that we have a lot of places in the world that are living very close to margins and very close to depleting resources, and they don't have the access to healthcare. And we're creating an environment that's just really ripe for the next whatever it's going to be.
And it goes back to your point about why didn't we see that many Marburg outbreaks that were that big in the past, right? So there's another thing that's happening, which is thankfully, we're getting better at detecting things. So my bounce back is that, yes, we're better connected. So maybe the outbreaks are better because we're better connected, but maybe the outbreaks are also bigger because we're getting better at detecting them. Wouldn't that be amazing? And I think the detection, surveillance, the capacity to be able to pick these things up, maybe they're always bigger and we just never detected majority of patients.
Yeah. No, I think that you're absolutely right. I know people sometimes come into the U.S. healthcare system and think we have that thing from Star Trek where we can just wave a wand over them and say, it tests them for everything. But people still die here in the United States, and we're not sure why, right? They had an infection we haven't identified yet. I mean, I was amazed at how quickly the science accelerated during COVID and how quickly we had a vaccine. And part of that was based on research that had already been done and sort of shelved for a while. And I think that same thing is true with these pathogens. Well, Naheed, it's just such a pleasure to talk to you about Marburg. I hate these opportunities. I wish that we were at a level of preparedness all the time, but we're not there yet, and we're going to keep working on that. But I think when these outbreaks occur, we want to get the correct information out to people. So I'd love to give you an opportunity to just say, if you just had nuggets, do you want to make sure people understand about Marburg?
Yeah, I mean, I think we said it before, which is close contact, bodily fluids, protecting yourself, and early care of patient is going to make all the difference.
Yes. Think special pathogens, intervene early, protect yourself, and remember to identify, isolate, inform. All right. Well, this has just been a pleasure. I really appreciate Dr. Bhadelia joining me today to talk about Marburg virus disease. We appreciate the work everybody does in healthcare, and we want to keep you safe. So if you need more information about Marburg virus disease, there are a number of assets at netec.org. That's netec.org. And there is also information there about PPE and PPE ensembles and donning and doffing and other things like that. For those of you listening at home, thank you for tuning in on this episode of Transmission Interrupted. We hope you'll join us for future episodes on a wide range of topics, from healthcare worker safety, just one of my personal priorities, personal protective equipment, another priority for me, and even more about infectious diseases of all kinds, whether they're special pathogens or not. So you can follow us at netec.org. If you have questions or ideas about future shows, you can contact us at info@netec.org. That's info@netec.org. And you can find us on the web, netec.org/podcasts, where you can also subscribe to future episodes of this series, Transmission Interrupted. So thank you, Dr. Bhadelia, and we'll see you next time on Transmission Interrupted.
You've been listening to Transmission Interrupted, the podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Learn more at netec.org.